اخر سبيكر في السيشن دي اخي العزيز الاستاذ دكتور ايمن فرغالي هيتكلم على الابديت on pulmonary hypertension management in view of the new guidelines. اتفضل دكتور.
شكرا دكتور محمد. طبعا احنا يعني we have a very hot discussion this morning about pulmonary hypertension. I'm just going to highlight some of the new guidelines remarks that have been published maybe 2 or 3 months ago regarding the treatment and management of pulmonary hypertension. Of course, pulmonary hypertension as a whole, as a big pool of pulmonary hypertension, the prevalence is 1% of global population. However, we shouldn't forget that most of the cases are due to pulmonary congestion, which is the post-capillary, due to left heart failure. Then we have pulmonary vascular disease, which is due to pre-capillary, due to lung disease. Again, this group we diagnose and we treat the cause, and that's all. The most important is the mean pulmonary artery and also the pulmonary vascular resistance. That's why the right heart cath is very important for diagnosis, because pulmonary vascular resistance usually denotes that there is a disease. These are the 5 groups of pulmonary hypertension that we have, and this classification is according to pathological and the pathogenesis and the pathophysiology. So we have the rare idiopathic group and the associated conditions, which is group 1. Then we have the big group of left heart disease, which can be isolated or combined. What's the meaning of combined? We have inherent disease in the vessels beside the left heart. Now we have the combined condition, and this group might respond to vasodilator. This is very common. Then we have the other common group, which is the lung disease, and we classify it into non-severe and severe. Only the severe cases that we discuss, because sometimes they have overlapping idiopathic disease. Then we have the only treat and the hope for the only group that can be cured, which is CTEPH, chronic thromboembolic disease. Chronic thromboembolic disease, if it is amenable to surgery, so end arterectomy is curable for most of these patients. And the 5th group is the unclassified. They are mixed group that cannot be classified clearly into group of the previous groups. So the therapeutic strategy is also very important for the clinical classification. So group 1 can be treated with the pulmonary arterial hypertension drugs or calcium channel blockers if it is vasoreactive. Of course, lung transplantation is the resort for all. This is the group 1, and as you see, it is diverse. We have the idiopathic, heritable, associated with drugs and toxins. We have the connective tissue disorder, HIV, portal hypertension, congenital heart disease, schistosomiasis, and the PVOD, pulmonary venous occlusive disease, and persistent PH of the newborn. This is the definition, and as you see, the definition have been changed. So we have the limit of only 20 millimeter to diagnose the pulmonary hypertension, but we have to get the pulmonary vascular resistance of more than 2 Wood units. This is the isolated post-capillary and the combined post-capillary. And what have been added to the last guidelines is the exercise. They have implicated the exercise again, and we have the definition of mean pulmonary artery over cardiac output between rest and exercise more than 3 millimeter mercury to diagnose pulmonary hypertension. The diagnosis actually is very interesting. Now, you can consider the algorithm for diagnosis of pulmonary hypertension as an algorithm for diagnosis of unexplained dyspnea. So in the general practitioner, and we were discussing this morning, what did the patient in the general practitioner or internist, what to do? So it's very important for him to have a good history, physical exam, ECG, PNP, and maybe oxygen saturation in order to suspect the case. So the suspicion is very important. And to put in mind, there is a diagnosis at the end of the day that it might be pulmonary hypertension. Then we have the lung disease and the cardiac diseases. These are the most common. About 85% of cases are due to, or maybe 90% are due to these two groups. So after that, if we have a patient who is, or she is, have warning signs that it might be PH, as Dr. Yusuf was speaking today, this case might be pulmonary hypertension, and this is a fast track. Don't waste time. Send it to a specialized center. So after suspicion, we exclude lung disease or cardiac disease, and this is the armamentarium of investigation that we do. And echocardiography actually is very crucial for diagnosis, and actually it is the mode of suspicion in order to screen for the disease. If the pH probability according to a specialized center is important in order to do right heart cath. So right heart cath is done to confirm the diagnosis and do vasoreactivity. It should be done in experienced center with suspected or known pH, include complete set of hemodynamics, and these are the hemodynamics that we get out of the right heart cath. So we have many things to do, and the most important is the wedge pressure and the pulmonary vascular resistance in order to know where is the patient is. And now, after diagnosing, we have to stratify our patient in order to know what is the kind of drug and what the kind of approach that we are going to do. So these are the kind of workup that we are going to do. So signs of right heart failure, this is a history, progression of symptoms, syncope, functional class, 6-minute walk test, and if cardiopulmonary exercise is available, we do. So these are going to stratify the patient into whether low risk with less than 5% mortality, intermediate risk having 5 to 20% mortality per year, or high risk which carries more than 20% mortality at rate. And now we know that ProPNP is very important, or the NT-proPNP. These are very important, and actually, when we do it, it can put the patient actually and we can give data which is very going with the right heart cath data. So ProPNP is very important. Then we go to the echo, and in echo, right atrial dimensions, TEPC over systolic pulmonary artery pressure, and no pericardial effusion are very important for diagnosis. This is the data that we are looking for. Cardiac MRI actually has been implemented in the new guidelines, and in hemodynamics, stroke volume index have been added. So right atrial pressure, cardiac index, SvO2, which is mixed venous oxygen. These are the data that we use in order to stratify the patient into low risk, intermediate risk, or high risk. And this is going to implement on the kind of treatment and the amount of treatment we are going to give for this patient. For follow-up, the situation is different. After I diagnose the patient, I give the treatment. After 3 to 6 months, I have to re-stratify my patient. And now we have only these 3 parameters. So WHO functional class, 6-minute walk test, and PNP. These are used to stratify or re-stratify the patient into low, intermediate low, or intermediate high. So this is the difference. In follow-up, we have intermediate low and intermediate high, and then the high risk. Intermediate high is treated usually like the high. These are very vulnerable patients, and this patient must be treated aggressively. This is the armamentarium of drugs according to the pathobiology that we have. We have 3 groups of treatment: the endothelin receptor antagonist, nitric oxide potentiators, and the prostacyclin analogs. These are the 3 groups that we have. And this is the algorithm for treatment. It is after the diagnosis, if the patient has cardiopulmonary comorbidity, we go with monotherapy. If the patient have no cardiopulmonary comorbidity, we stratify. If he is of low intermediate risk, we initially give endothelin receptor antagonist. If it is high, we give endothelin receptor antagonist plus BDE5, which is sildenafil or tadalafil, and the regular follow-up is carried out. So this is the resume of treatment. Patients without cardiopulmonary comorbidity, we risk stratify. If it is low intermediate, we give ERA plus BDE5 inhibitor. If it is high, we have to implement IV prostanoids. So IV prostanoid remain the treatment for high risk people. Patients with cardiopulmonary mobility are going to take monotherapy because of the side effects of the drugs with the comorbidities of the heart. After risk stratification, we re-stratify the patient. If he is remain low, we still on the initial therapy, we don't change it. If the patient is intermediate low, we add prostacyclin oral prostacyclin analog like the Selexipag, or we switch, and this is new, from the BDE5 like sildenafil to soluble guanyl cyclase, which is riociguat. Intermediate and the high are going to be treated with IV prostanoids. So these are the recommendations for initial oral drugs. And as you see here, taking a class 1 is ambrisentan and macitentan with tadalafil. However, in the other endothelin receptor with BDE5 should be considered, and it takes class 2A. Why? Actually, this is because of some side effects that have been clarified in the COMPASS-2 study. So there is some interaction between the bosentan and sildenafil. However, if you look here with tadalafil, the side effects are much less, and that's why we advocate the use of combination of bosentan together with tadalafil and not sildenafil in order to avoid this interaction, because Professor Tageddin was saying that we have to take care of the economics, and now we have many of the pharmaceuticals and with the drugs on a national companies, and they are available. So we have to use it judiciously in order to offer the treatment for all of our patients with proper that is going to be lessening the complication, and we can avoid the side effects and better action of them. We never forget that bosentan is recommended treatment for idiopathic. Whenever you have Eisenmenger syndrome, the class 1 treatment is bosentan, up till now as monotherapy. This is the suggested assessment and timing in follow-up. And as you see, we use this schedule of assessment and function. It's available. This is the echocardiogram, ABCD with partial symmetry, disease-related quality of life, and cardiopulmonary exercise actually is going to have more part in the future if it is available, and right articles. And we always say, whenever you have a question, whenever you have something which is not clear, the hemodynamics will answer. That's why whenever we find the patient is not going properly with what we are doing, we go to the right heart cath and see what's going on, and usually you get the answer. So our take-home message is very simple. Guidelines are a work in progress. So we have accumulated data, and we have to implement it with our practice and with our data. And stepwise approach to optimize risk stratification is a key, because this is an outcome of hell of research. And actually, out of this, we have recently done our consensus, Egyptian consensus for treatment. and diagnosis of pulmonary hypertension. And very soon it's going to be published. And I hope in the very coming few months, we are going to talk about our Egyptian consensus for treatment of pulmonary hypertension in view of the world guideline. Thank you very much.